Welcome to the Healthcare Authority's Health Home Program, which is now coming to King and Snohomish counties. A little bit our program. Washington State's Health Home Program is a partnership operated by two different agencies, the Healthcare Authority and the Department of Social and Health Services. The Healthcare Authority is the Medicaid agency that oversees Washington Apple Health and is responsible for the contracting and enrollment of clients into the Health Home Program. The Department of Social and Health Services is responsible for delivering mental health services, substance use disorder treatment, and long-term services and supports. Together, the two agencies provide a good balance of medical and social perspectives for the overall Health Home Program. Section 2703 of the Affordable Care Act defined the requirements of health home services. Washington submitted a state plan amendment in order to offer health home services in 37 of 39 counties. In addition, Washington was one of 15 states to be awarded a Centers for Medicare and Medicaid Financial Alignment Demonstration Grant to help alleviate fragmentation and improve coordination of services for high-cost, high-risk individuals who receive both Medicare and Medicaid benefits. The demonstration is the first time that states have had the opportunity to receive shared savings by reducing Medicare costs. Our initial results from the Health Home Program for the first year and a half has saved millions of dollars in Medicare for Washington. Having two state agencies jointly manage the Health Home Program capitalizes on the core strengths of each agency and provides a more seamless and timely process to make improvements when needed. It also helps provide a good balance of medical and social services when making policy decisions. Starting in January 2017, Washington will add the last two counties, King and Snohomish, which will result in statewide coverage of the Health Home Program. Some basics about the program. Health home services are really a new set of optional Medicaid benefits available to eligible clients. Participation in the Health Home Program is voluntary and at no cost to the clients. Health home services do not duplicate those currently being delivered. Care coordinators step in when a service is necessary and not already being provided, bridging gaps where needed. Health home services are not only clinic-based. One of the unique aspects of the Health Home Program is the requirement for care coordinators to be community-based, meaning they know their community resources and visit clients at their home or a location of the client's choice. To make sure the Health Home Program was sustainable, we knew we had to focus on high-risk clients. This population has the best possibility to decrease hospital and emergency department use as well as nursing facility stays. Many of these clients also have extensive health challenges resulting from social determinants of health such as homelessness, isolation, lack of transportation, and language or cultural barriers. Washington's previous experience with the Chronic Care Management Program, as well as national studies, support targeting high-cost, high-risk clients for intensive care coordination services through the Health Home Program. These clients have the best potential to improve their health and reduce costs as they are much more likely to need multiple Medicaid services. Health home enrolled clients truly benefit from the high-touch, community-based care coordination that the program provides. This slide provides some details on why the Health Home Program focuses on high-risk clients, as they are most likely to have healthcare service needs in multiple delivery systems. For instance, the graph shows the use of non-medical services broken out by those who are receiving Medicaid only and those who are also receiving Medicare, which are called duals. At the top of the graph, you can see that 62% of the duals over the age of 65 receive treatment for substance use disorders or for serious mental health illnesses. And nearly 4 out of 5 receive the long-term services and supports. We also find high service use among the dual disabled population. 67% of this population receives treatment for serious mental illness. Over 1 in 4 receive substance use disorder treatment, and nearly half receive the long-term services and supports. In contrast, the numbers are different for clients who only receive Medicaid services. As you can see, while 25 to 37% of the Medicaid disabled population uses multiple services, the non-disabled Medicaid-only population shows that only 1 in 10 receive treatment for mental illness, and the use of long-term services and supports is even lower. The need for multiple services is even lower for the non-disabled Medicaid group. This group is not your typical high-cost, high-risk client targeted for the health home care coordination services. Care coordination and integration of the separate Medicaid funding streams is where clients may benefit most from the health home enrollment and services. The Health Home Program was designed to be person-centered, which focuses on providing the tools and supports to empower clients to improve their own health. As a result, clients have a better understanding of how to address their healthcare needs, which in turn helps reduce avoidable costs. Health home care coordination is not only medically based, but reaches all service providers, including specialty care, behavioral health providers, and long-term services and supports. We also wanted to ensure care transitions are better coordinated, as this is a situation in which bad outcomes not only have a negative impact on clients, such as rehospitalizations, but also increases the total costs of care. The Health Home Program provides a way to bridge the systems of care between all providers, which in turn helps decrease duplication of efforts and also identifies potential gaps in care that, if addressed, keep clients healthier for longer stretches of time. This map of Washington shows the 7 coverage areas across the state where health homes are currently available. As mentioned at the beginning of this presentation, in January 2017, King County will be our coverage area 3, and Snohomish County will be added to our current coverage area 2. Please also note that Clark and Skamania counties in coverage area 5 of Southwest Washington became fully integrated managed care counties in April 2016. This is just another way to integrate and purchase healthcare through the managed care plans for Medicaid clients. Getting to the details of this health home presentation, this slide shows the total number of health home eligible clients in King and Snohomish counties only. If the program was available to King and Snohomish counties in August, almost 29,000 clients could be receiving health home services. More specifically, 21,000 eligible clients in King County and 8,000 in Snohomish County. So how does this health home program work? The Healthcare Authority has two functions in the health home administrative structure. One is to contract and pay health home lead entities, and the other is to enroll eligible clients with the health home lead entities. The qualified health home lead is then expected to subcontract with community-based care coordination organizations, also known as CCOs. Health home lead entities receive enrolled clients from the Healthcare Authority and then assign the clients to the most appropriate CCO using a SMART assignment process. The SMART assignment process is based on current providers or areas of expertise needed for the client's care. For example, older adults may be assigned to the local area agency on aging, contracted as a CCO, while a client with severe mental illness would be assigned to a participating community mental health agency, also contracted with the lead entity as a CCO. The health home lead is also responsible for other administrative duties, such as mailing health home program information and materials, reporting the client-centered health action plan data to HCA, and reporting the reimbursements made to their contracted CCOs in the form of encounter data. As this slide shows, some leads may have more CCOs based on the population and program eligibility, and some CCOs may also contract with more than one health home lead entity, which in turn could increase the number of clients the CCO would serve. So where do you fit in? The Healthcare Authority is looking for health home lead entities to serve the dual eligible and Medicaid fee-for-service clients in our Coverage Area 2 and Coverage Area 3. New organizations interested in becoming health home lead entities will have to apply through the state's request for application process. Later, we will provide more information on how to become a health home lead entity. The managed care organizations contracted with HCA for Apple Health enrollees will be the health home lead entities for their enrollees, who are also eligible for health home services. These MCOs are looking to contract with community-based care coordination organizations to provide the health home services. As mentioned earlier, health home services are Medicaid-covered benefits and paid for by the state through its contracts with managed care organizations and health home lead entities. As a care coordination organization, you can expect payment for the services provided. Washington developed a three-tiered payment system to pay for the health home services. Tier 1 includes payment for your initial contact with the client to arrange face-to-face meetings to confirm the client's desire to participate in the health home program, complete required assessments, and to develop that health action plan. This is a once-in-a-lifetime payment, and the typical payment to the CCO for these services is $227.64 per client. Tier 2 includes payment for at least one face-to-face visit between the care coordinator and the client during the month in which other qualifying health home services are provided. The typical monthly payment to the CCO for this service is $155.35 per client. To clarify, this monthly payment per client would cover all intensive care coordination services provided during that month. Tier 3 includes a maintenance rate when the client is ready for self-management of their own health care, and includes payment for the periodic home visits and/or telephone calls to reassess healthcare needs. The typical monthly payment to the CCO for this service is $60.75 per client. In our contracting, the healthcare authority allows each lead entity to keep 10% of the total rate to cover their administrative costs. Not all Medicaid clients are eligible for the Health Home Program. This slide shows the eligibility criteria. To cast the broadest net for high-risk, high-cost clients, Washington included an extensive list of physical and behavioral health chronic conditions in our eligibility criteria. Clients of all ages must have at least one chronic condition and be at risk for a second. Because we want to focus on the high-risk, high-cost clients, eligibility for the Health Home Program also requires a Prism risk score of 1.5 or greater. Prism is a web-based tool used for predictive modeling, providing a prospective medical risk score, like the 1.5 score, that measures the expected healthcare costs over the next 12 months based on the client's disease profile and pharmacy utilization in the past 15 months. This algorithm also takes into consideration the client's age, gender, diagnosis, and medications. As of May 2016, in the 37 counties where Health Home eligible clients are enrolled for services, we have a total of 71,014 eligible clients enrolled, with 5,806 actively participating in the program. There is plenty of room for more great care coordinators. There are 6 specific Health Home services that are payable through the Health Home program. The first is a comprehensive care management. This service provides assessments and interventions tailored to the client's needs. It includes the development of the person-centered health action plan with goals and action steps to achieve those goals. Next is care coordination to assist with communication and referrals between clients, direct providers, families, and other caregivers. Health promotion not only provides educational materials, but uses coaching methods to support self-management and recovery. Transition care planning is the participation of the care coordinator in appropriate phases of care transitions between institutions and community settings to include discharge planning, home visits, medication reconciliation, and any follow-up care. Individual and family supports is another service helping to support the client and their family or caregivers to maintain and promote quality of life with a particular focus on community living options. Referrals to the community and social support services may also be provided to access services such as food, transportation, and legal services. This may also include working with the client to maintain eligibility for healthcare services, disability benefits, and housing assistance. Health Home Services also includes access and use of health information technology, such as using the Emergency Department Information Exchange System as notification of clients who are admitted to the emergency departments throughout the state. A quick look at the Health Home Program's Health Action Plan, or HAP. This is consistent with the program's focus on person-centered engagement to improve health conditions, the client must agree to develop a health action plan that identifies at least one personally prioritized goal for improving his or her health, actions the client will take to achieve the goal, and the supports to be provided by the care coordinator. The completed HAP includes information on the client's health conditions, screening or assessment scores, and the long and short-term goals. With the consent of the client, the HAP is shared with their healthcare providers as well as case managers embedded in the service delivery system and family or community support systems. The HAP and screenings are updated on a 4-month cycle with the client. A health home care coordinator is an individual who provides and oversees health home services. Care coordinators can be nurses, physician assistants, social workers, behavioral health, and/or chemical dependency professionals. We encourage the use of a team approach where allied staff, such as community health workers, wellness coaches, peer support specialists, and others, work with care coordinators to provide all of the health home services. We have seen allied staff used for outreach and engagement, making referrals for the services and supports, and calling clients for medical appointment reminders. This is one way to help make the program more fiscally sustainable. What are the training requirements for a health home care coordinators? The state provides extensive training for care coordinators, which includes relevant information and skills building. The mandatory 2-day sessions focus on program philosophy, care coordination functions, the use of Prism, developing health action plans, outreach and engagement techniques, patient activation measures, motivational interviewing and coaching, behavioral health, and care transitions. Each health home lead may also require additional training related to their specific operational requirements. Care coordinators must complete this training before they can begin to develop a health action plan with the client. There are also 6 one-hour mandatory webinars that must be completed within the first 6 months of becoming a care coordinator. Additionally, monthly optional webinars for care coordinators are available on a range of applicable topics. Is the health home program working? Yes, yes, and yes. Health home services are changing lives and reducing costs. We have heard many success stories since the program began. The next slides describe only 2 of the successes of the health home participants. This client's original long-term goal was to play wheelchair basketball, with a short-term goal to help get the wheelchair repaired for better stability. Getting a community resource and local medical equipment store to help in adjusting the wheelchair, the care coordinator was able to build trust with the client. This trust-building process led to another goal, which was to reduce the pain medication the client was taking. Once the trust was built, the care coordinator was able to accompany the client to his doctor's appointment. This is where the care coordinator found out that the client was drinking a 1/5 of alcohol per day. The care coordinator worked with the client's provider and made a referral for detox, followed by a 21-day stay in treatment. Today, the client is doing much better now and has set new goals. With the care coordinator, they are working on getting in housing that will bring the client closer to family. Talk about costly care. This client had 63 visits to the emergency room in just 12 months. The client was using the emergency department for congestive heart failure problems and shoulder pain. She had run out of medications and had not taken them for 3 months. Through the Health Home program, the care coordinator was notified of this client's latest visit to the emergency department. The care coordinator was able to get the client's consent to participate in the Health Home program. Afterwards, the care coordinator worked with the client to establish care with a primary care physician and a cardiologist. To help the client communicate her problems to the providers, the care coordinator accompanied her to appointments. The client is back on her cardiac medications and a new medicine for her shoulder pain. She has not needed to go to the ER in 6 months. Keeping the success stories going forward, if your organization is interested in becoming a health home lead entity in King or Snohomish counties, this is the qualification process to follow. The qualified health home lead entity will be responsible for providing health home services to the entire coverage area, as shown on slide number 7 with the map. Again, coverage area 3 is King County. Coverage area 2 includes Snohomish, as well as Whatcom, Skagit, San Juan, and Island counties. In order to become a qualified health home lead, the organization must have an adequate community-based care coordination organization provider network. The request for application was released on August 12th and posted on the Washington Electronic Business Solution, or WEBS, website at the web address shown on the slide. It includes the full RFA schedule and how to access additional information or ask questions. The Health Hope program also needs care coordinators who understand the specific needs of the clients that we serve. If your organization is interested in becoming a care coordination organization, the first step would be to contact the current health home lead entities in your area to express your interest. The health home lead entities will set up time to talk with you about their contracting process and answer any questions you may have. Healthcare Authority will provide you with the lead entity's contact information via email sent to the health home email addresses on the next slide. However, your next step would be, after this, to execute a contract with them and receive health home client assignments. As a CCO, you will also need to secure access to Prism to ensure you have all the client data that is vital for the care coordination purposes. This is done after your care coordinators complete the basic 2-day health home training. Completion of the 2-day training is a requirement before care coordinators can develop a health action plan with the client. The health home lead entity will help you with this process, as there are some additional steps that will need to take place once you are contracted so that payments can be made for your services. There is more information about the Health Home program on the Healthcare Authority and DSHS websites. We have also included email addresses for Agnes Erickson, and Karen Fitzharris, as well as our General Health Home mailbox. Please feel free to contact us with your questions. Thank you for listening to this webinar.